Okay, great. So my name's Karen. I'm one of the anesthetic GASOC reps. And today we have the pleasure of welcoming Dr. Rennie Kin to present to us a paper on building sustainable and resilient surgical systems, a narrative review of opportunities to integrate climate change into national surgical planning in the Western Pacific region. Rennie is a surgeon and a researcher based in New Zealand, and she's had over 10 years of experience in research, training, advocacy, policymaking in the areas of global health and climate change. So without further ado, I'm going to pass over to Rennie, who will present to us her very important paper.
Great, thanks so much, Karen. I'm just going to begin by sharing my slides. Hopefully this will work for everyone. Can you see my slides okay?
Yes.
Okay, excellent. I'll get started. Thanks, Karen, for the introduction. My name is Rennie Ching. I'm a general surgery registrar from Aotearoa, New Zealand. So warm greetings to everyone. Our tēnā koutou katoa is our greeting in Te Reo Māori. So today I'll be presenting a paper that we published in Lancet Western Pacific 3 years ago in 2022. And this is on building sustainable and resilient surgical systems, opportunity to integrate climate change into national surgical planning. This paper was published in a Western Pacific regional journal, but the implications are not only limited to Western Pacific countries and is very relevant to your parts of the world as well. So behind every academic project, there's a personal story. And my journey in climate change started 13 years ago when I was a youth delegate at the United Nations climate change negotiations. There, I saw the negotiator from the Philippines, Yap Sano, in tears as Typhoon Haiyan ravaged his country during the conference. I traveled to Leyte a year later and spent summer volunteering and cooking school lunches. And I could see the devastation from the typhoon on the ground more than a year later. At the conference, I had a taste firsthand of the global injustice as Yap Sano was ignored by negotiators from high-income countries. The really scary thing is, a decade later, we don't need to travel far to see the reality of climate change. Climate change has become a daily happening around us, whether this is heat waves in Europe, wildfires in Australia, cyclones in the Pacific, or recently in Auckland, we've had the worst flood in history about 3 years ago. As you can see, people are kayaking down the street near where I live. And just in the last week, we've had 3 thunderstorms from extratropical cyclones between Easter and Anzac Day. The latest IPCC report has 3 key findings. Climate change is not just in the future, it's already a part of the reality around us. And we will exceed 1.5 to 2 degrees of warming in the 21st century under all projected scenarios. And most importantly, every action counts because the impact of climate change is not only on increasing averages, but also extremes. With every additional increment of warming, changes in extremes will be bigger. Therefore, every bit of mitigation in reducing climate change and every bit of adaptation in minimizing the impact of climate change will count in producing a future that is as normal as possible. So the impetus of the paper I'm presenting today stemmed from my work with 5 Pacific Island countries in developing national surgical plans, and this was during my research fellowship with a program in global surgery and social change at Harvard Medical School. During a stakeholder consultation meeting, a stakeholder pointed out the fact that climate change was missing from the Lancet Commission on Global Surgery. And there was very little literature on the intersection between climate change and global surgery at that stage, and even less literature on adaptation. As a part of this work, ministries of health in the Pacific asked how climate change could be integrated into surgical system design. And this really is a twofold process. Firstly, our surgical systems have to be sustainable. We have to mitigate and minimize our impact on climate change. And secondly, they also need to be resilient to the effects of climate change and adapt to the impact of climate change. And we realized our Pacific neighbors cannot do it alone because high-income countries emit much more greenhouse gases than low and middle-income countries. In fact, one of the papers we looked at as a part of this review demonstrated that emissions from minimally invasive surgery in the United States alone is more than the total national emissions of some countries in the world. So therefore, we realized high-income countries such as ours, and also the UK have the ability to make much more of an impact through adopting sustainable surgical practices, and we have a responsibility to do so. So in conducting our narrative review, we framed it as being relevant to both high-income countries and low and middle-income countries across the Western Pacific region. We searched several scientific databases between July to September 2020 using a range of keywords and mesh terms that relate to climate change, greenhouse gases, and carbon footprint, and also surgical anesthetic and obstetric care. We also performed a hand search of key grey literature and key policy papers through organizations such as the World Health Organization and the Intergovernmental Panel on Climate Change. We included all relevant papers and excluded papers that weren't published in English. We performed 2 levels of screening, first by screening the abstracts and then by screening the full text of papers. And we performed narrative synthesis using the modified World Health Organization building blocks framework, which is based on the 6 pillars of service delivery, workforce, information management, infrastructure, finance, and governance. And I will present our findings according to this framework. So in terms of the first domain of infrastructure, we found that the operating theatres are among the most energy-intensive parts of the health system. They are 3 to 6 times more energy-intensive than the rest of the hospital. 30% of emissions associated with surgery with anesthesia excluded is from the built environment. And this can be reduced by improving the energy efficiency of operating theatres through occupation-based ventilation, LED light use, and also renewable energy use. The second component of infrastructure is equipment and consumables, and they contributed to 70% of emissions from surgery, with anesthesia excluded. And this can be reduced throughout the equipment lifecycle. Firstly, starting with procurement, environmental preferable purchasing can select equipment based on their long-term financial and environmental cost rather than their upfront cost. Secondly, the number of instruments in a surgical set can be rationalized to the minimum required. And thirdly, proper segregation of biohazardous waste can reduce the amount requiring incineration. Lastly, reprocessing instruments have been found to have a significantly lower cost and carbon footprint than single-use devices around the world. However, we found some variation. For example, in Australia, where electricity comes mainly from coal, which is a very carbon-intensive source, we found that re-sterilization can lead to a slightly higher carbon footprint in certain circumstances. And this really highlights the fact that as health professionals, while we make changes for sustainability within the health system, we have to look at the broader society as well. And health sector sustainability cannot occur without overall energy sector decarbonization. In terms of the second domain of infrastructure, we found surgical care has a lot of impact on carbon footprint. So this can be through the method of surgery. So most papers found laparoscopic surgery to have a higher greenhouse gas and carbon footprint than open surgery. But a lot of these papers did not take into account the environmental benefit of minimally invasive surgery across the entire perioperative period. For example, the benefit of laparoscopic surgery in reducing the length of stay across the entire life cycle of the patient by reducing readmissions from sequelae of open surgery down the line, such as adhesive bowel obstruction or incisional hernia. So there is scope of reassessing the carbon footprint of laparoscopic and open surgery by taking into account a much longer timescale. At the time of this review, there hadn't been many studies comparing robotic surgery, laparoscopic surgery, and open surgery. However, most of these studies did show that robotic surgery had a higher carbon footprint than laparoscopic surgery. And this is mostly from single-use consumables. And the clinical equipoise between robotic surgery and laparoscopic surgery is much closer than that between laparoscopic surgery and open surgery, in which there will be a lot of clinically justifiable cases that patients should undergo laparoscopic surgery because of the quality of care that they are provided. In terms of the location of surgery, performing clinic-based surgery where possible, such as minor skin operations and even carpal tunnel release, has been found to reduce emissions associated with an operating theatre environment. Telemedicine and outreach can also reduce emissions from patient travel. And studies based in New Zealand more recently have found that in some rural areas, because our population is much more dispersed than the UK, patient travel can account to up to 40% of the carbon footprint of some procedures. And in terms of anesthesia use, which is a huge component of carbon footprint of operating theatre as well, our anesthetic colleagues have done a lot of research on this topic, and the recommendations are for avoidance of nitric oxide and desflooring, which have the highest carbon footprint amongst the volatile gases. The use of total intravenous anesthesia where clinically appropriate, and the use of regional anesthesia where applicable. In terms of the wider spectrum of services around surgical obstetric and anesthesia care, diagnostics are also associated with a high carbon footprint, and this can be reduced by using laboratory tests in a rational manner by reducing unnecessary use. And also endoscopy, interestingly, has been found to be the third highest emitting hospital department. Not only does surgical care have an impact on climate change, but climate change also has an impact on surgical care delivery. In terms of direct impact, climate change can increase the burden, range, and complexity of diseases requiring surgery. And examples include necrotizing skin infections, schistosomiasis, skin cancer, renal colic, traumatic injuries from extreme weather events. And as a part of this, strengthening local surgical systems have been found to be a rapid and effective means of providing a disaster trauma response. And this is currently the focus for some of the ministries of health in the Pacific. In terms of indirect impacts, climate change can impact the comorbidities affecting surgical care through increasing the rates of NCDs, undernutrition, and access to clean water, which can affect sanitation. And this can increase the rates of postoperative complications and infections. Climate change mitigation can also bring about co-benefits for surgical obstetric and anesthesia care. For example, by increasing physical activities, we can reduce carbon footprint from fossil fuel-based transport, and we can also reduce the incidence of NCDs and the perioperative risks associated with NCDs. In terms of finance, sustainable surgical practice are not only a moral and existential imperative, but they can also generate cost savings and make care more patient-centered. Many initiatives, such as improving building energy efficiency, minimizing surgical tray size, telemedicine, and outreach, can also save cost, and they can make care more accessible for patients. In terms of information system, environmental sustainability currently is not incorporated as a key indicator in many health systems around the world. However, it should be a key performance indicator for surgical systems. Research has found that carbon footprint correlates with healthcare access and quality up to a certain point, as we can see on the graph in the right. However, beyond a certain threshold, say if you compare France to Japan and the USA, health systems such as the US can have a much higher carbon footprint with similar, if not inferior, qualities compared to the other countries. Therefore, high carbon footprint is not an inevitability within the health system, is something that we can actively control through how we design health systems. There's a need to document and share research on this topic and innovations around the world, especially from the Global South. For example, we came across a paper in Aravind Hospital in India, which was able to provide cataract surgery at 5% of the carbon footprint compared to a hospital in the UK through adopting a package of sustainability practices. In our review, we also found that research on this topic was extremely limited, and the current evidence is based on a few studies from a small number of facilities. And as we demonstrated in the case of single-use versus reprocessable equipment, the carbon emission profile of surgical care and solutions to reduce them can vary across the world. Therefore, there's a need for a lot more data and research to be generated from every setting around the world, so we can find the most high-yield solutions for us in every region. In terms of workforce and governance, which are the last two domains in the framework, sustainability should be incorporated into the educational curricula of surgical obstetric and anesthesia providers. And beyond changing our practice at the individual and departmental level, we also have the responsibility to advocate for institutional and national change. For example, environmental preferable purchasing at the hospital level and sustainable and reusable instrument design at the industry level. I think since the publication of this paper, I've seen a lot of single-use instruments coming out to play. For example, at the moment, the companies are trying to market single-use endoscopes to us. So I think there's definitely a creep towards more unsustainable practices, even since the publication of this paper. Surgeons have a track record of successfully influencing policy changes. For example, neurosurgeons in the past and trauma surgeons have played a critical role in terms of seatbelt use and helmet use legislations. And therefore, we can do the same with climate change. And beyond being professionals, we are also citizens, and a part of our role is advocating for policy changes in our countries to reach emission reduction targets at a national level beyond the health sector as well. So in conclusion, we found climate change mitigation must be an integral component of surgical, obstetric, and anesthesia care scale-up across low and middle-income countries. Surgical care strengthening is also necessary for adaptation to climate change, especially in response to extreme weather events. And both are important components of resilient post-COVID health systems towards achieving the Sustainable Development Goals and universal health coverage. In terms of the strength and weakness of our paper, the strength is that it covers a novel and important topic. We had a comprehensive search strategy that was able to assess all of the literature on this topic. The weakness was that there was still a scarcity of literature and a lack of primary studies. And the paper itself was of an interdisciplinary nature, so more evidence will emerge as more primary studies are conducted. So that's a summary of the paper so far. But I just really want to take a pause at this point and reflect on changes in the last 3 years since the publication of the paper. I think for me, the paper was only a starting point, and there's a lot more to be done on this topic in our lifetime and in our professional career going forward. So since the COVID-19 pandemic, I think there has really been a reversion back to business as usual, and there has been an increase in greenhouse gas emissions around the world. The 2024 Lancet Countdown on Climate Change has found that there is a resurgence in fossil fuel use since COVID times, and currently fossil fuels still constitute a third of global investment, which is pretty astounding. We've really seen an increase in extreme weather events around the world every day, and this is a constant reminder that climate change is going to be a part of our reality in the future and right now. I think the really scary thing is that this is the first time in history where our children will have a shorter lifespan than us. And the IPCC health chapter can clearly link causation of climate change to diseases around the world. And I think it's going to bring about profound changes in our reality going forward. Something else I've thought about a lot more since the publication of this paper is the deeper question behind health system sustainability. And I think that question is, do our health systems really truly deliver care that's suited to the needs of communities and the planet? And I think the answer to that would take us back to looking at the determinant of climate change. And climate change has always been framed as an Anthropocene. It's something that's caused by human action. But as we found out, it's not caused by the action of every human being around the world. It's caused by a particular culture that's propagated around the world through colonization. And it's caused by a particular worldview that sees the environment as separate from human beings rather than being an intrinsic part of us. For example, here in New Zealand, our indigenous population, the Maori people, actually have a very different worldview. Just last year, Taranaki Mountain has been named as the first mountain in the world that's a living being. So the indigenous worldview sees the environment as an intrinsic part of who we are. And as opposed to there being harmonious relationships between human beings and between human beings and the environment, Colonization has stemmed from a worldview that sees other human beings and the environment as having extractive values. So really, this is the underlying determinant of climate change. And this is very well summarized by a paper that's published by several academics from my university, which is in the bottom right corner, navigating the fundamental tensions towards a decolonial relational vision of planetary health. So how does this relate to surgical system sustainability? I think we need to, so taking a step back beyond the 6 pillars we've presented in the paper, we need a broad framing of sustainability and resilience in surgery. And our traditional approach is on very behavioral, technological, and ad hoc changes inside the operating theater. For example, today we'll use alcohol swabs, and tomorrow we'll use renewable gowns. It's through these really micro level kind of interventions, which is very important and it's very achievable. But in order to effect long-term sustainable changes, we need to examine things at a much deeper level. And this needs to be outside of the operating theater across the entire health system. It needs to be policy-based and value-based and institutional. And we have to transform surgical care fundamentally towards being truly be able to provide what patients and the planet need. So I just want to provide a few examples from my recent thought that captures this question to challenge everyone, and I hope that this will provide a springboard for discussion as well. So I think the first area for future practice policy and research is really around examining low-value care, and this is particularly relevant in high-income countries. So currently, in my daily clinical practice, I ask myself, is the care that I deliver what patients really need? You know, how much unnecessary treatment is provided, for example, for patients with asymptomatic hernia? And how much unnecessary investigations is provided, for example, surveillance CT scans? What really brings about quality of care for patients? Is it correcting a treatable biomedical abnormality, or would it actually bring about an improvement in their quality of care? Is the treatment we provide matched to demand? And I've seen a lot of inequities across diseases. For example, colorectal cancer receives a lot more treatment than lung cancer. And that stems from a moral framing of us seeing lung cancer patients as doing it to themselves, as having individual responsibility over their disease, but ignoring some of the higher structural causes around the tobacco industry. And here in New Zealand, we have inequities across ethnicities. So some people are receiving too much treatment and other people are receiving far too little treatment. And as we provide treatment to more and more people, we also see more and more iatrogenic harm. So I think the fundamental question of sustainability in surgery is that we have to have stewardship over our resources, and we have to re-examine, is the care we deliver, is it partly driven by what we want to do as surgeons, or is it really what patients truly need and want? And the second area for future research practice and policy is around the surgical devices industry. And the question is the surgical devices industry oriented towards the needs of the people and the planet, or is it oriented towards profit? And I think the answer of that is pretty obvious. But how can we influence it to be the other way around? And I think there's a lot of this scope for collaborative studies to assess the variation of surgical equipment and instrument used for common procedures. For example, in New Zealand, the hospital I work in currently has really fancy equipment, we have a single-use laparoscopic camera cleaner, a camera wiper, and also a port cleaner, which other hospitals may not have. So can we minimize our equipment use around the country? And I think the sustainability of robotic surgery is going to be a huge area for investigation as well, as robotic surgery is used more and more. And if robotic surgery has a role for some surgical procedures in the future, then can we make it more can we make it more sustainable? Can we influence industry to manufacture more reusable consumables rather than single-use consumable? And currently, surgical equipment and instrument availability, suitability, cost, and sustainability in low and middle income countries has not been very well studied. And I think this is another big topic to examine. I think we need to hold industries accountable by assessing their practices with scorecards. And there's a lot of scope for surgical devices innovation in low and middle income countries as well. In terms of other directions for future practice policy and research, there is scope to bring care closer to people through outreach, telemedicine, and also care coordination. And resilience and adaptation remain really understudied topics in this subject. And this would entail looking at the occupational health standards of operating theatres, waste management strategies, emergency response to extreme weather events, and community level strengthening has been shown to be an important indicator of resilience on the ground. And we need to shine light on local innovations across the global south. In terms of the values that must drive future practice in this area, this should be driven locally by low and middle income countries around the world. And as opposed to adopting a dominant Western perspective with colonization, we need to decolonize our knowledge systems and incorporate diverse knowledge systems and worldviews around the world, especially ones that value environment as an intrinsic part of human health, so we can build health systems that are fundamentally oriented towards what people need and also what the planet need. In terms of funding, I think we are at a crossroad in global health at the moment, with the current Trump administration pulling funds from USAID, from global health initiatives. But I think this is a critical point that we need to re-examine global health. I think we need to look at alternative fundings for surgical care, and potentially mobilizing some climate change funds can be an avenue for this. We also need to actively reverse resource flow out of low and middle income countries. And I think surgical devices industry is actually a good example of this, because currently low and middle income countries are spending a lot of money purchasing equipment and instruments which are not suitable to their context, which is really high cost and not sustainable, not easily processed locally. So how do we build innovations based in low and middle income countries to actually provide the surgical devices and instruments that low and middle income countries need? And I think as health professionals, in addition to engaging with the health system, we also have to engage with economic systems. And the question would be, how can we include both health and the environment in our economic system? Because currently, both health and the environment are externalities. They aren't currently being valued and being counted in our economic system. So the talk might have left everyone on a really grim note, but I do have hope. And this is a picture from my trip to Yosemite National Park in the States last year. And I think there I just realized the profound amount of change our world has seen in the last 150 years. California was colonized 150 years ago, and New Zealand was colonized 150 years ago. And there has been profound changes in landscape, economy, values. I guess in the past, a lot of that has been towards the worse. But I think our generation, we are recovering from the trauma that the previous generations have experienced. I think we are recovering from the trauma of colonization, the movement of our ancestors across the world. And I think with climate change, we really have to do a fundamental reevaluation of our values. And I think this is an opportunity for us to build a better future. It's an opportunity for us to build health systems and a future society that values relationships between human beings and our relationship with the environment. And in the room, we're all surgeons, obstetricians, and anesthetists. We're all healers. And I think the question for us is, in our future practice, how can we heal in a way that's truly suited to the needs of our patients and the planet? And I think working in the space of climate change, resilience, and sustainability, especially through taking a higher health system approach, this is what we can achieve. And I think there are immediate practical actions that we can all take every day. So I will leave on this note, and I will open up the floor to questions. Thank you. Ngā mihi nui kia koutou.
Thanks very much, Rennie. That was a very inspiring talk, and I love how you've brought in your own experiences into your research, and I've loved hearing all your thoughts on sort of having done the research, how that's sort of shaped your thinking around sort of climate change and surgical systems. We're now going to open the floor to any questions. And unfortunately, we're not able to allow the participants to speak, but I'd really like to involve people who are listening as well. So I have a question for the audience as well. And I just wanted to ask, have you seen or could you share any good examples of where you've seen good sort of climate mitigation or adaptation in your own settings, and what are some of the challenges, or what are some good examples where clinicians have advocated for the environment? So if you can type it in the chat box, we can sort of read them out. So I have a question from Donald. Thank you, Dr. Chin. Thank you for the great presentation. I wonder what your thoughts are on simple practical steps healthcare professionals can take to become effective advocates for more environmental, sustainable approaches during their busy day-to-day work. Any simple examples that you have seen in your area of work? Given the existing financial limitations on many healthcare systems, how do you think we can make an effective argument for areas that are likely economically viable in the long term, but would attract a significant upfront cost? For example, setting up outreach or telemedicine services. So I think that's two different questions.
Great. Thanks, Donald, for your question. And sorry, I can't hear anyone speak on this platform. We just have to read out the questions. I'll tackle the first one. So I think there are lots of examples of simple practical steps, and it depends on where you are and the kind of practices, the kind of unsustainable practices that exist in your hospital. So for example, as I've alluded to, I've kind of returned from rural hospitals and I'm practicing in a tertiary center at the moment. And I've seen lots of practices that aren't sustainable by comparison. You know, a really simple example is we don't have compost in the cafeteria here. So it doesn't even need to be in the operating theater. It can be any part of the hospital. We don't have food waste, compost, so everything just goes into the rubbish. And in terms of practices on the ward, so anything you can do to reduce resource use can also reduce carbon footprint. So examples is I've seen initiatives by others to reduce the amount of IV fluid used before patients go to the operating theatre. So there's an initiative called SIP until SEND. And my colleagues have done analysis on the cost saving of this, but also equally you can do analysis on the carbon footprint saving. And also inside the operating theatre, colleagues of mine have done really simple initiatives. For example, switching all disposable gowns to reusable gowns. The College of Surgeons in Australasia have position papers on using alcohol-based hand sanitizers as opposed to the traditional scrub brush for surgical scrubbing. So in the literature, there are definitely lots and lots of examples of simple practical steps. It just depends on what's going to work the best in your hospital. I think it is hard to brainstorm when we're busy, and I think something that can help a lot is having networks, just having a group of colleagues that you can come together to share ideas and also keep track of how each other is going in their own setting. So just going to your second question now, which is on the financial limitation of in health systems in terms of limiting sustainable practices. So a lot of sustainable practices actually saves money rather than the other way around. For example, as I alluded to, the laparoscopic camera cleaner. So we have a fancy camera cleaner, which is single use. You put the camera in there for 5 seconds. And we also have a fancy port cleaner, which is single use. I mean, they cost the hospital money. So I'm thinking, why do we have it? Is it because as surgeons we want it? We ask for it. The hospital is paying extra for it. I think in terms of, and same with robotic surgery, it costs a lot of money. In the States, my friends actually tell me that the industry persuade the hospital to use robotic surgery. So you have to really ask what's the motivating factor around it. Is the industry actually driving what we as surgeons practice? So in terms of the specific example you've included, such as setting up outreach or telemedicine, outreach is low cost, and that's actually used, I'd say, a lot more by my colleagues in the Pacific than myself in my practice. And I wonder if that's really based on different values within different health systems. I think in the Pacific, health professionals do place greater value on bringing healthcare closer to patients. And I think that's also from a non-Western kind of worldview. In New Zealand, we have a very rural setting, and I think we have a lot more scope of doing outreaches. And really, it's very low tech. It just involves one clinician driving to a town, in a car and doing a day of clinic or doing a day of kind of easy clinic-based surgery. So a lot of these initiatives actually have very little upfront cost, but even for ones with a high upfront cost, one can perform life cycle cost calculations, and a lot of these initiatives are very cost effective in the long term.
Great. I think we've also got a question from Ryan saying the example of France was interesting. Are there any specific examples from France or the cluster of countries around it for achieving the high quality care to low carbon emissions ratios noted in the table? Is there any data on an economic correlation, i.e., would it be expected that the nations in that cluster are all high income countries?
Yeah, thanks, Ryan, for your question. So the countries in that cluster are all high-income countries because they do have a high quality of healthcare. So I can share my screen again, just to bring up that particular slide. Let's just look at this slide. So yeah, so the countries at the top end of the y-axis are pretty much all kind of high-income countries or middle-income countries in the case of China and Russia, because they've reached a high level of healthcare access and quality. In terms of the difference between France and Japan and the US, I think a key factor is actually the privatization of health system. And there have been studies showing that private health systems, as opposed to being more efficient, they actually have a much higher carbon footprint. And this is because there's a lot more, I think there's a lot more kind of low value care provided. There's a lot more unnecessary investigations, unnecessary treatment, because these health systems are more driven from an economic perspective rather than being driven by patient need and patient demand. So they are more driven by, reimbursement from insurance companies, earnings of clinicians. For example, in the US, I think pay per care service models are much more common. So surgeons actually get paid based on the number of surgeries you do. So if that's how you are incentivized, why wouldn't you book all the asymptomatic hernias or the minimally symptomatic hernias from clinic? You would book them because you make more money. So I'd say that would be the key difference between some of these health systems.
That's great. We have a comment from George from, I think, Nigeria, who has commented on how most surgical systems developed mainly from Western countries. So in our certain, there was a shift from, basically in their setting, there was a shift from use of fitted disposable gowns, but they have now shifted back to reusable gowns, which has reduced the cost significantly for both emergency and elective surgery, which has contributed to almost 10 to 15% of cost of surgery. And he's commented that industry also has an influence in cost of surgery because of technology for monetary gain. For example, consumables for laparoscopy, but not encouraging peritoneal dialysis compared to hemodialysis. So that's an example in a sort of LMIC setting. And then I've got a question from Fijna asking if there is potential tension between competing priorities. I'm curious about how healthcare systems facing a significant burden of disease and operating with limited resources are able to maintain a focus on sustainability. While the link between climate change and the surgical system is clear, as you have highlighted, in many settings, the immediate priority often remains delivering the best possible care to individual patients. In such contexts, addressing urgent clinical needs may understandably take precedence over longer-term sustainability goals. How can such systems keep sight of sustainability?
Thanks, Karen. Yeah, I think firstly, it's a very insightful comment from George, and I think I agree completely. And I would be very interested in any kind of examples of surgical devices, innovation from low and middle income countries, and also any kind of surgical devices industry development from LMICs. I think the difficulty is also that I think nowadays training has been strengthened quite a lot more in global surgery. But traditionally, if you have a surgeon from a low and middle income country, if they go to a high income country, they kind of, they come back having adopted the practice, the equipment that they were used to in high income countries. And I think that can kind of limit the imagination of what is possible in LMICs as well. So I think the surgical devices innovation piece will be very interesting going forward. And I think that's a part of how we can actively reverse the resource flow from the global north to the global south as well. So going back to Vina's point, sorry if I'm mispronouncing your name, and feel free to type in the correct pronunciation. I think this really kind of goes back to the point that I don't see it as a conflict as such. And I think because nowadays climate change is, it's being portrayed as an emergency, and it is, but I think it doesn't take away from the fact that we must address the root cause of climate change, and we must build health systems with the right value from the beginning. So I don't really see a conflict between urgent clinical needs and sustainability goals, because I think fundamentally it goes back to health systems, how health systems are designed, and the values underlying these health systems. So, for example, in Fiji, in the Pacific, my colleagues, have many urgent needs, clinical needs to take care of. And one of the solutions that they've come up with to do this is by doing more outreach clinics and surgeries, because they have a shortage of space in referral hospitals. So they are taking care close to patients in first level hospitals. So I don't think it necessarily needs to be a conflict, and maybe it is a conflict because that's the framing of Western health systems. I think we can build health systems with the right goal from the beginning. And another example is the one from India, where I've referred to during the talk. A hospital was able to provide cataract surgery at 5% of the carbon emissions compared to a hospital in the UK. They actually did a direct comparison of these two hospitals. And they found that the hospital in India, because it had much quicker turnover, there was shorter sterilization cycles, and really quick turnover of cases, they were actually able to really efficiently use their resources. So in a way, maybe the urgent clinical needs prompt us to be more sustainable. Maybe we have to be more judicious of our resources. And another example is actually in the States, because they have a private health system, and profit is a lot more important. So actually in the States, more hospitals are reusing instruments such as the ligature because they are so costly. So some of these private hospitals are actually figuring out ways of reusing and re-sterilizing these single-use energy devices. So I think we have to look after ourselves. We have to build alliances. But I don't think there's necessarily a contrast between attending to urgent clinical needs and integrating long-term sustainable goals. And I think we can look beyond this conflict by designing health systems with sustainability and with community needs at its core.
That's great. I think we have just one last comment, which is from Donald. My experience of working in a hospital setting in Zambia was that the staff from the admin to clinical at all levels were much more aware of the cost-benefit analysis of their interventions. For example, malarial bed net for mesh hernia repair, making their day-to-day work naturally more sustainable than the work I see here in the NHS UK. I feel the NHS and likely other higher income settings has a lot to learn from those working in lower middle income regions. So I think with that, we're going to conclude our webinar today. Thanks everyone for contributing. Just as a sort of plug for sort of GASOC events coming up, we have our conference on the 24th and 25th of October. I'll try and upload the